So, first, let me say, I didn't say this last week, but I want to make sure I tell you that how fortunate you are that your leadership would give you these 2 days to take. It's not taking the day off, but it's doing something different. It's enriching you and furthering your professional growth and knowledge base. So I hope that you will thank Lisa and Christine. I think I got their names right. Yes. Because this is, you don't see every hospice across North Carolina doing this. In fact, it's few and far between the folks who put this much resources into making sure that your staff are increasing their knowledge base, and because it really can help you in the long run. As you know, if you only take a few pearls away, then it hasn't been in vain. I hope that all of you'll go take the exam at some point in time. But if they do, the recommendation within the candidates book, if you read it, it said that they like you to have 2 years experience. You don't have to, but it just makes it a bit easier for you to take the exam, and you have a better handle on patient care and pain management, symptom management. So again, I think it's very admirable that they are allowing you to do this. So with that, we'll go ahead and get going. You've got your objectives. I'm not going to take time to read through those. But there are some symptoms that are pretty common at the end of life. And we'll look at those, and we'll also look at etiologies that may be present, that may be contributing to whatever symptoms you're seeing.
I've got 2 more highlighters if anybody wants them.
Thank you.
Oh, well, go ahead. No, go ahead.
You share this?
We'll share it.
I may have one.
So, we talked about the consensus project last time, and the 8 domains. Well, here we talk about the domains, physical aspect, domain number 2, and the guideline for that is that pain and other symptoms and side effects are managed based upon the best available evidence that we have. And we give attention to the disease-specific pain and symptoms, skillfully and systematically applied. And I would also put in there methodically, because when you're dealing with pain or symptoms, what's one of the key factors that we learned last time? We need to start how?
Low.
Start low and go slow. Low and slow, that's right. And the goal of pain management, symptom management is what? To use the least amount of medication, right? To get the maximum effect with the least amount of side effects. That's a mouthful, and that's a goal that we should strive for.
Where are we?
Where are we?
Yeah. Sorry, right in the middle.
Yeah.
Page 1.
I don't know.
I can't find the page 1 that we're on. I keep going to the wrong page 1 or something.
Well, we skipped around this time. We're going to do the
Yeah.
large module first instead of the short
I
module.
just can't find where it's.
So we get the elephant off your back to begin
Oh,
I
with.
did.
right.
I did.
Oh.
Down there.
Oh, I said you get
You
it.
get it?
Okay.
Everybody with us?
Yeah.
I was sitting.
So the first symptom that we look at
Here, sign right here for this day 2.
is anorexia and cachexia.
I didn't say down there either.
Are y'all familiar with those? You see a lot of patients with these 2 particular symptoms.
Yes.
Yep.
And do you know the difference?
Yes.
What's the difference?
Anorexia is just not wanting to eat.
Cachexia is when they can eat and eat and eat and it still doesn't make a difference necessarily.
Losing weight.
And it really becomes evident. You start seeing it, don't you? They just waste away.
Anorexia is more what patients tell me. They
What you're looking at. And they do sort of go hand in hand at some point in time within the trajectory. What's the prevalence of these 2 symptoms? We commonly see it in advanced disease. 80% of your cancer patients, you may see cachexia. And it may be the cause of death in 20% of these patients. So again, we need to keep them as comfortable as we can, when we are, dealing with these particular symptoms. What might cause it? Well, it might be disease related. It may be infections, and those infections could be systemic, or they may be oral. It may be some sort of thrush. It could be herpes. It could be, is it stomatitis? Could be that. Could be, have y'all seen other reasons that a patient's mouth might be sore, and that may be why they're not eating?
Due to radiation treatment.
Radiation. Could even be something as simple as their dentures don't fit anymore. And maybe their gums are sore because their dentures are flopping up and down. They may not tell us that.
And then some people are coming in, have lost a lot of weight.
Right, because they don't generally go get their teeth, those dentures readjusted. Constipation, to some degree, if it's chronic constipation, can cause people to have a loss of appetite. Metabolic alterations, pain. You ever have patients that say, I just hurt so bad I don't have any appetite anymore? We really need to work on that pain and see if we can't get that pain under control for those patients.
Decreased activity.
Exactly, they're not burning any calories, so they don't have, and that's what, I mentioned my mom, and I use her as a case study all the time, but she doesn't do a whole lot, so when I'm on her about eating, she's like, well, I hadn't done anything today, and I'm like, okay, you win. So that's really true, that if you're not doing anything, you may not be hungry. I wish that were the case for me, but
I know, starts out.
well, it doesn't happen with me, and I see all this candy up down this table. So y'all work your brain hard today so you burn some calories, because you got a lot of sugar there. Oh Lord. Some other physical symptoms that might be secondary that can contribute to anorexia might be pancreatitis. If patients eat, have you had patients who've had pancreatitis? Really painful. Those were some of the sickest people that I would see come in the emergency room complaining of extreme, excruciating pain. And I'm going to see if I can say this word. I'm going to say this because you may see these words again, these medical terms for abnormality in taste. Do you know what the medical term for that is?
Anosmia. Nope.
Dysgeusia?
Oh, dysgeusia, yes.
Yeah. If you want to know how to spell that?
Yeah.
DYS?
DYS, that's right. Got that dys right. GEUSIA. And I do remember seeing, I don't know which one of these words it was, but I remember this being a question on the test that I took, which I took last year. That's not to say it'll be on yours, but I would just say be familiar with these words. Also, use them in your documentation. It can save you writing a bunch of words to use one word, because that is the symptom that we're talking about. So that is an abnormality in taste, especially an aversion to meat. And then if you put a ageusia, what would that be?
No taste.
The loss of taste, that's right. And I heard someone say, did you say hyperosmia?
I said anosmia.
Anosmia, okay. That would be the absence of the sense of smell, and that is ANOSMIA.
And that's no smell?
Yeah,
Yeah, no smell.
makes you not be able to taste your food either.
Right.
Apparently.
And then if it's osmia, what would that be?
Decrease.
Decreased. You still got some, but it's decreased. And you know, this, as I think about this one, this could be a safety hazard too for patients, because if they can't smell, if they got a fire in the house, they're not gonna be able to smell that smoke, right? If there's gas leak in the house, they may not be able to smell that.
That's scary.
So, just something to be aware of. It affects more than just eating. And then hyperosmia would be
Very
increased.
sensitive to smell.
Right. And I think we find that sometimes when you have a patient with nausea, they may be able to smell something that we can't smell. Or it may make them, it may be certainly more intensified for them. Now, do you want to sit, you want to sit at the table? Okay. Well, there's a table over here, we still have it if anybody wants to sit
Sit over here.
Those chairs are
The chair that you're sitting in, so it's empty.
Sit up here.
Right.
And it's my understanding she won't be here tonight, so.
No.
I think that's a joke,
I'll be
but she can sit, we'll resituate here, she can sit there.
Last come, last served,
I was
that's how
gonna
it
say,
is.
it's gonna be.
I know, hey, I called in. They
Down there,
picked
she
it
go,
over.
what'd she say? What'd she say?
Yeah.
So when you're dealing with palliative care patients, you may also see dysphagia. You're aware, you know what that means? Difficulty swallowing. You may see dyspnea. And what would that be?
Shortness of breath, difficulty breathing.
So when you see DYS, you know what that stands for?
Alter or
Difficult.
difficult.
A is gonna be absence, and I know you learned all this in nursing school, but just for review, if you're sitting there at the test and you're trying to figure out what this word means, that little bit of knowledge might be helpful to you. And hypo. Other symptoms that you might see with palliative care patients might be nausea, vomiting, diarrhea, constipation, obstruction even. These can certainly affect their appetite, people don't want to eat. And then alcohol or substance abuse disorder also may be present with people too. Especially if they've had if they've been an alcoholic for a long time and they've got some stuff going on in their gut. Maybe some stuff that's not reversible. So causes, treatment related. For both of these, it may be that the medication may be causing the anorexia. We see this sometimes with what type of medications? Something, antibiotics, don't they make you sometimes just don't want to eat? What else?
Pain medicine can.
Pain medicine can. If they've had chemotherapy. Also, medications that are used to treat HIV will sometimes make patients nauseated. Chemotherapy, radiation treatments might be problematic even after the treatment's ended. And you may see people who've had radiation a long time ago. We may be seeing them now, and they've got residual from the radiation they had a long time ago. It wasn't as sophisticated then as it is today, is it? And we still have patients who get burns if they're having chemotherapy or radiation around the throat, the head area. So just things to be able.
Strictures in their soft.
They do. They do. Other causes, psychological and spiritual distress. And many times we overlook this piece. And we can't see it, so we just fail to mention it or look for it. Also, if you've got a patient who's depressed, they may, if the depression has gone on for a while and it can get into a major depression, these people may not have any appetite. And they're probably not doing anything either, which don't help. But
Anxiety.
anxiety.
It does me like that. My stomach gets all tore up if I'm too anxious. I can't eat.
Yeah, it can go that other way too. So, but making sure that we address those psychological and spiritual, that spiritual distress. If you can't find anything else going on with that patient that might be causing this, then be sure to assess them for depression or for spiritual distress. Because there's not any pills we can give that are gonna fix that, I don't believe. I haven't found any yet, hadn't heard of any yet that's gonna fix that spiritual distress. So how do we assess them? Well, we listen to them. They tell us. You may see the presence of weakness and a lack of energy. They may talk about being so tired and so fatigued. You may see weight loss, and they may get where you can't weigh them, but you can do measurements, right? How, do y'all do, you do body measurement? Okay. BMI. So you may see, with the muscle wasting, you may see the energy levels drop, and they just aren't doing any activity because, and when you ask them about it, maybe they just don't feel like it, they can't do it. If you're doing labs, and with your palliative patients, you may be doing some labs, you may see some indication there lab work is off. They may become anemic, and then looking at their intake patterns. What's their food? What foods do they like? What foods don't they like? Determining the meaning of food for them. What does it mean to them? Or does it mean anything? Is there pain associated with their eating? If pain's associated with our eating, are we gonna eat?
No.
Here are some medications from a pharmacological standpoint that could be used with anorexia, cachexia, if there's not any indication that they should not be used. Megace is an appetite stimulant that could be used. It is contraindicated if you got a patient who has thrombophlebitis or thrombophlebitis. You don't want to discontinue, if you're using Megace, you don't want to discontinue it abruptly because it can cause hypertension and it can also cause thromboembolisms and peripheral edema. You might use Reglan, Decadron, or Miranol. Which one of these or any of these do you use if you have a patient that you're concerned about their eating?
All of them.
Yeah,
All of
we've used
them?
them.
Do they usually come to you on these, or is this something that the IDG will determine they need?
It depends on how, if it's a distressing symptom to them or not,
Okay.
and how far along they are in their disease process.
And it may be somebody that comes to you, they just don't eat. Because if my mama came to you today, if you admitted her today, you'd probably be real concerned about the little amount of food she eats. But it's what she lives on, that she, so that history that you take, that intake is gonna be real important. Because it's like beating your head on the wall if they don't wanna eat. But it may be you may have a different scenario because there may be some reason that they don't eat, as we've talked about. Non-pharmacological interventions that might be used, you want to treat the underlying symptoms if there are any, which we talked about a few minutes ago. Give emotional support for the patient and the family. Because families really get upset when patients won't eat, don't they? Especially if you have to tell them, it's really not safe to feed the patient anymore. We'll get into that later, but feeding is it's symbolic, isn't it? It's symbolic of loving and caring and nurturing our patients and families. And when I've heard people say, yeah, she went to hospice and they just starved her to death. And it takes some, if you don't have a relationship with those patients, it's really hard for them, or family, it's really hard